Good afternoon, everybody. I see we are an intimate group in a massive room, so be prepared. We're going to get you to move around a little bit, but just for the moment, I'll let you stay where you are, okay? So welcome. This is a session, it's an organized session on the subject of multiple funding flows and incentives, and asking the question, how does provider payment and the mix of provider payment systems that providers face shape their behavior in low and middle income countries? So just by means of background, this piece of work actually draws together two separate pieces of work. So one was some work that was done by WHO that was responding to requests from the ministries of health in Tunisia, Morocco, and Burkina Faso to support some policy dialogue on the subject of provider payment methods. And one of the issues that emerged was the fact that in these countries, and indeed everywhere, that there are multiple provider payment systems in operation. And so there was an effort to apply this analytical guide for assessing mixed provider payment systems. And this was predominantly, it was research done as part of the policy dialogue with national ministries of health, and it was done using qualitative methods. I'm going to say, you can respond or object, Fahdi, but it wasn't done as a research project. It was done as a policy dialogue project. So that's the one stream of work. The other stream of work was some work that was done by RESIST. So RESIST was a research consortium funded by DFID, led by myself and Lucy Gilson from the London School of Hygiene and Tropical Medicine, with collaborators from various parts of Africa and Asia, but particularly including Vietnam, Nigeria, and Kenya. And we had done some work early in the consortium on purchasing, tracing the operations of purchasing organizations across all of our consortium members, but very much looking from the perspective of the purchaser. And we did lots of case study work, wrote some reports, and kind of by the end of it realized in a way that we hadn't fully appreciated the need to look at this from the provider perspective, and I'll explain why very shortly. But this work was based on case studies that explored this idea of multiple funding flows and used a mixture of qualitative and quantitative analysis. Now, we knew these two teams, as we did the work, we knew each other were doing it. So we actually cross-reviewed each other's protocols and had in mind this sense that we were going to be coming out with some very similar ideas, and we were applying similar concepts and ideas. And so when we had finished all of the work, we came together as a team to revisit the conceptual frameworks that we had independently developed and to revisit our data together to see if we could build something that was greater than the sum of the two different studies that had been done somewhat independently. And so this session is really the place where we're presenting for the first time the work that draws together the work of the two teams. Now, I would say that it's had some challenges. We've struggled for a long time around language and what we call these things. And I think you'll see that we've come to some views about what we should call them. We've also got slightly different methods. We've got because the RESIST work was done as a research study, we have things like transcripts and quotations that we can use to evidence some of our arguments, whereas the WHO policy dialogue work just wasn't done that way. So we've had some challenges in drawing together the evidence, but I think that we have been very successful in developing a picture that's much richer than either team could have achieved on its own. So this, in this session, what we're going to do is this. So I'm going to kind of present the common conceptual framework that we agreed upon. And I failed to say I'm billed as Edwine Barasa from KEMRI Wellcome Trust. Edwine was not able to join us, so I'm standing in for him, but you're welcome to call me Edwine if you like. So I'm going to present really quite briefly. Then Fahdi, who the WHO team, is going to present a summary of the results across all 6 country studies. So that's going to take about half an hour all in for the two things. We'll have some time for questions right after that. And then we're going to break up into groups. And I realize we have a challenging space for group work. You know, Catherine, you've got to stay for the group work. There's no slipping out in between. We're going to have 3 groups. One is going to focus on what does the future research agenda look like following this work. One is going to work on policy options, answering this question of how we can move to a more coherent, less fragmented system. And then the third group is going to talk about some of the challenges of governance of these mixed provider payment systems. So that will allow about 20 minutes or so of discussion, a bit of a chance to summarize the discussions back to the big group. And then we will have, in the final few minutes, we'll have some discussants' comments from Joe Kutzin from WHO. So be prepared to move, but you can stay put for now. Does that sound okay as a plan? You're all still here. That's because it's too rude to leave. Okay, so I'm going to present the conceptual framework that we developed for analyzing this thing that we call multiple financing flows, and think about how we might develop some options for aligning. So the very first thing I want to say is, if this is a picture of the health financing systems, on the left we have revenue generation, in the middle we have pooling, and then we have the third function with the star, which is purchasing. So this work falls very much into that part of the health financing system, which is about purchasing and about making purchasing more strategic. So as I said, when we did our first phase of work, we very much took the purchaser's perspective. So in fact, across our 7-country studies, which then expanded to 10, we looked at almost 20 different purchasing mechanisms and looked at multiple mechanisms within each country, but very much kind of from the top down. So like you might see in that picture over there, we looked at one at a time. And we looked at the way that a single purchasing mechanism or a funding flow is described by the services that it's used to purchase, the population group that it's supposed to cover, the method of payment that it uses, the level or rate of payment that it uses, and also the accountabilities around that. So what sorts of reporting were required for a particular type of for a particular funding flow, but also what relationships that entailed between the people it covered, the providers it contracted from, and the government as the overseer of that. But it was very much top-down and very much kind of looking at one flow of funds. And I think kind of as we reflected on our findings, it was really, we discovered that actually if you think about it from the provider's perspective, they don't just get one flow, they get very many flows. And they get very many flows, each of which is characterized by a set of services, a population group, a provider payment method, some accountabilities, and a rate. And so there's multiple purchasers, and these providers face these flows that are potentially incoherent. So if you think about the idea of trying to get some signal from your revenue flows. You have money flows as sending signals to providers about what to prioritize, what to do, what populations to serve, what services to provide. When you've got lots and lots of funding flows that are not designed to be coherent, you can get a lot of noise and perhaps not as much signal about what providers should do. And that, we hypothesize, can really undermine health system objectives. And so the next stage of our thinking was to say, well, so what are the attributes of a funding flow and therefore of a mix of funding flows? So one, you can think of for each one, what is the overall contribution that it makes to total facility revenue? So it might well be that you've got some funding flows that are responsible for a greater share of facility revenue, and facilities might be more responsive or more attentive to the signals that are sent by that funding flow. But they can be, you can almost think of it as a concentration measure. You could have one dominant one and lots of small ones, or you could have lots of funding flows that are of fairly equal sizes. A second characteristic of this funding flow is whether the level of payment actually covers the cost of the service it's supposed to provide. Now, we know that many, many places have their provider payment rates set really quite independently of cost. So it may well be that to different degrees, these payment rates cover or fail to cover the marginal costs of services. We can also think about how much flexibility or autonomy managers have over the revenue that they generate from this flow. It might well be that it's tightly controlled through public finance rules, or it might well be constrained in what it can be spent on, or it could be very open and up to the discretion of the provider to decide how to use the money. The burden of accountability or the complexity of accounting for those resources could be quite different. The predictability may be very different. So in many highly constrained systems, revenue does not arrive on time or in a predictable way to health providers. And in fact, you'll see some evidence about the difference, say, between fee-for-service, where you don't necessarily know how much revenue you're going to earn in a month, compared to, say, capitation, where you have a very clear and predictable flow of funds attached to your enrolled population. And finally, they may differ according to their performance requirements. So whether they're linked to some kind of, whether payment is linked to some kind of performance requirements. And I think that the key insight here is that each individual funding flow doesn't affect provider behavior in isolation. It actually combines with all the other flows to produce a sense of the signals that providers respond to. So this is the next step in the framework then. So we are able to identify and to describe these funding flows. And then the next question is, well, what might providers do in response to them? So one thing that they might do is shift resources. So for example, if you are in Kenya and you have quite a generous funding flow that comes from the National Hospital Insurance Fund for civil servants, you want to create special facilities for civil servants because that's how you can attract more revenue. So that sense of, and those special facilities, they require shifting resources towards them. So you can have civil servants, clinics that have shorter queues, better stock, better meals, better amenities, all those things that go along. So that sense of shifting resources towards a more favorable funding flow, that's what we mean by resource shifting. The second is that you can shift kind of people towards services. So you can direct your patients from the public lab to the private charging lab. So actually moving services towards a more generous resource flow. Or you might do something that's called cost shifting, where you actually charge more to the more generous payers. And this is an idea that comes from, I guess, some of the observations from the US, where private insurers tend to pay more for a given service than public payers do. So it's related to the notion of moving the revenue streams around depending on the generosity of the payment for a service that is the same. So you're paying different amounts for exactly the service. The third bit of the framework then says, so what is the impact of this? So how does the provider response to these different funding flows lead to health system outcomes? And so the third part of our research is trying to identify the extent to which equity and efficiency and quality are potentially compromised by these provider responses to the multiple funding flows. So I can see some faces that are familiar that were in the session yesterday afternoon where I presented some of this. So I want to make sure that we build on it. One of the things that occurred to me yesterday, and it came up in the discussion, was that multiple funding flows isn't really a good enough label to distinguish the different types of fragmentation that we might see. So I suppose what we're really talking about here are multiple funding flows that arise from multiple payers who might have multiple payment mechanisms, but in a sense the system is developed by accident, incoherent, it's not designed to be such. At the bottom is a system which is very common across across health systems, more so in high-income settings, where you still have multiple provider payment systems or multiple provider payment mechanisms that a provider faces, but it's in the context of a single payer. So in the UK, for instance, you have GPs who receive capitation, but they also receive fee-for-service for very specific services, and they might actually receive some performance-based funding for achieving certain targets. So we're not saying that your entire system has to be aligned to a single provider payment mechanism, but rather that where they are mixed, they should be mixed by design and should contain what are relatively coherent incentives. The middle part is kind of the interesting one. So if you're starting at the top and you want to get to the bottom, but it's often not possible to merge across payers, it's still possible to generate more aligned payment systems by thinking about the sorts of things that you could align. So you could still have the same provider payment mechanism across different funding flows, or you could have a common information system across funding flows. So there is an intermediate step here. So one of the objectives of the discussion later this afternoon is to think about, well, what sorts of things could you do to get from the top, if not all the way to the bottom, if the merging across pools is impossible, how can you at least get to a more aligned, more coherent system that delivers some stronger signals? So these two sets of activity then, the WHO-led one and the RESIST-led one, have actually done what's the same thing, which is go through this kind of process of policy-oriented analysis. So the first step was to map out the funding flows and to begin to attach some magnitudes to them, so we have a sense of which are the larger and most important ones. The second was to explore the incentives that are attached to each of the funding flows. The third, to try to identify how providers were responding to the mix of funding flows by prioritizing certain services or patient groups or by shifting costs. And then this last stage has been to think about how do we actually bring coherence to what is a very fragmented system. And so on that moment, I'm going to hand over to Fahdi, who is going to present more of the results of this work that we did. After Fahdi has spoken, we'll pause for some questions.
So, yeah, okay. Thanks a lot, Cara. And as Cara explained, this is part 2 of the session, which aims to draw the lessons we actually got out of the analysis of the 6-country analysis we ran in 2 different sets. And as she finished her presentation, and I would frame it slightly different, we shared common questions. We were wondering what are the different payment methods applied by the different purchasing agencies in the national health systems. What are their main features? What attributes do these funding flows present once they reach the providers? How do these funding flows incentivize provider behavior? And what are the implications of these changes in behavior on the health system's performance and objectives? So more or less what Cara finished with is just to reframe the way I interpreted it. And I think the focus of today, of the results we will share, will be mostly on the 2 last questions, hence they are bold. So the study type, it's a bit of a non-identified flying object, NIFO, sorry, in a way, because indeed we compared 2 sets of studies which on our side, WHO, we don't do studies. We are not an academic institution. We conduct assessments, analysis on request of ministries, but we thought, let's try to find a way to bring those 6 cases together in a way and draw lessons from it. And that's why we do that multi-team work on a sample of 6 analyses, as mentioned by Cara, in Burkina Faso, Morocco and Tunisia for WHO side, and in Nigeria, Kenya, and Vietnam on the RESIST side. And the idea was to apply and develop that conceptual framework and use it to revisit data collected from the 6-country analysis. The focus was mostly on adaptive behaviors. and which can be understandable from an organizational perspective in a way to increase profits or to reduce workload on the provider side, but which potentially hamper efforts towards UHC. And more specifically, we fleshed out signals, and I insist on the signals side of it, it's mostly qualitative, of resource shifting, service shifting, and cost shifting. The data collection method are data extraction of qualitative indications of provider behavior in response to multiple funding flows. The delineation of the potential causal link, we did it that way. First, we extracted all the observed behavior that we could from the different studies, and then we tried to analyze the drivers to these behaviors. Can we, out of these different analyses, draw drivers to this? And also, and you will see how challenging that was for us to draw the consequences of these behaviors on health systems performance. So, but the first step was for us to clearly map out the different purchasers, the different purchasing mechanisms or methods at play, and the different funding pools. And I won't go into details into that table. It's just clearly the lessons that we can draw, and that's only on the 3 first countries, is that fragmentation of health financing architecture has permeated to the purchasing function. And what we found also interesting, if you look now, that's the 3 other cases, for Tunisia, you see different payers using similar payment method, or at least on the title, the mode is the same, is the fee for service. But in reality, because it's not just about the mode, it's also about all the requirements and all other accountability behind, these are not the same funds. These are not the same flows coming to the provider. So the multiple payment methods are used in each country, that's one fact, and with little coordination mechanisms. That's one of the clear findings from our mapping exercise. And it creates room for providers to turn these multiple payments to their advantages. And this way of playing with these funding flows can have positive or negative consequences. But it's also very clear that it's not about blaming providers. The provider behavior is a rational response to funding, the response to the funding flows, attributes, and incentives. And there are 3 forms of three types of behaviors we identified, as I explained earlier. And the first one is resource shifting. And we found out 3 forms of resource shifting. First, resource shifted to preferred health financing arrangement. And this is the case, for example, in Nigeria, where NHIS clients clearly have shorter waiting times compared to those who will pay out of pocket. And we have here a quote from Nigeria Focus Group, and when they see them, they take them directly to the doctor, even when someone is in front of them. That is called express services. When I come to see the doctor, they will bench me, while they will take other people to go and see the doctor. It is wrong. So on top, the person is not very happy with it, but that's clearly a way to show that you put more resources to cater for this financing arrangement here, the NHIS arrangement. Then the second one we saw is resource shifting to preferred ward or services within the facility. And as Kara mentioned as well, we saw that, and that's an example here from Vietnam, where patients receiving on-demand service. So the public facilities can provide on-demand services within their public facility, but these ones, they can be charged to the patient. And these services are provided in special wards by higher skilled specialists and with better equipment. And the hospitals are not bound by national standardized payment rates for these specific services, hence they can charge more or less whatever they want for those on-demand services. So the provider tend to shift resources to be able to generate more resources from these services. And the last one is to preferred population. We've seen resource shifting to cater for specific groups. And that's, for example, in Kenya, where hospitals put in place special procedures to provide services to civil servants and protect them against one specific issue of drug stockout, for example. The difference between the general population and civil servant, as the mid-level manager says, is if we have a medicine that is out of stock, for the general patients, they will have to go and buy it for themselves. Yes, but for the civil servants, we have arrangements with a private supplier who gives it to them and invoices it to the hospital. The second type of behavior, the service shifting that we observed as shifting services, was the first case, moving cases from one funding flows to another for greater convenience. Again, in Kenya, providers encourage uninsured patients requiring long-term or elective surgery to enroll into NHIF, so that the provider can benefit from a more secure and higher payment rate for service delivered. We usually encourage people to do the NHIF cards because we consider them more important, and it is actually even more important to the hospital when we have the cards, as we get higher returns. The second case is moving cases from one provider to another as a strategy to transfer financial risk associated with service provision. And that's, for example, the case in Nigeria under the mandatory health insurance, where outpatient services are paid using capitation. Health provider dissatisfaction with the capitation rate triggers unnecessary referral, as shown by the quotes here. Well, the truth about is that they try to treat as few people as possible under capitation. For some hospitals, they try and move most treatment and most element to have the secondary services as quickly as possible. Somebody that is treating for malaria, for example, may give chloroquine, and once it has failed, they will call you and tell you that you want to refer to an internal medicine specialist. The treatment has failed just so that they can take off the burden of giving additional drugs under primary healthcare, which is capitated. So they try to push everything for fee-for-service when they are going to get extra money. So this idea of moving cases to higher level just to get rid of the burden associated with it. And finally, the last one is cost shifting. So forcing patients, for example, into funding arrangements which are more beneficial for providers. And again, from Nigeria, tariffs for patients paying out of pocket are higher than those applied to mandatory health insurance members for the same service. An example for cesarean section, which is for 150,000 naira for out-of-pocket patients, while under the NHIF tariff list, it's only 55,000 naira. So the provider are therefore tempted to make patients pay out of pocket when they are, even when they are insured. Sorry. So the drivers, the second question, as I said, was what drivers can we identify, and those related to attributes of the funding flows. So first, the adequacy. The adequacy here is perceived in three different ways. First, there is an absolute value behind what I would, whether the payment rates are considered to cover the cost of providing services. That's what the providers reported. If it's considered as enough, in a way, to cover the cost. And then there is another analysis of the adequacy is as compared to other services paid by other purchasers for the same service or similar services. So that's what we call the relative value. And the third one, the third dimension, is the profitability of the payment rates. The second drivers that we identified is predictability. There is appreciation of the predictable regular transfer of payment reflected in the discourse of an hospital manager in Kenya, for example. With capitation, you can predict how much you are going to get as a healthcare provider. But that's not everywhere the case. Like, for example, we mentioned Nigeria, where capitation rates are seen as too low. So here we will come back to that, but it really varies from one place to another. The third drivers that we saw was the regularity and stability of funding flows. Example from Burkina Faso, if well operated, the PBF incentivized providers to put additional resources on the range of services targeted by the PBF program. However, as soon as disruptions or interruptions in payment occurred, the incentives changed drastically. You do everything you can to fill up the requirements despite the workload because we knew we would get something. Now that the PBF is over, people are less motivated. There is a loosening because what's your personal benefit now, except for those for whom it is really their vocation. So less effort made by people there. And finally, the drivers linked to the attribute of the funding flows is the accountability requirements and mechanisms. And here again, it drives the change in behavior because in Morocco, these requirements explain why hospitals public hospital will favor funding flows coming through budgetary allocation over those paid through claims. The challenges is enhanced by the lack of skills administrative personnel and law compliance among medical staff in terms of reporting requirements. And that's the quote: often when we send a bill to our national health insurance schemes, the time limit to submit them has already gone, mainly because we lack administrative personnel to fill up the claims, but also because doctors do not fill up the medical records as per requirements. When we try to look at the consequences for the health system and health system's performance, well, we moved that part to the discussion section because it was actually very difficult to create that link. What we have is qualitative indications of obvious equity issues with equity breach in horizontal equity principle, what we could otherwise term as patient discrimination. And we saw that with differential in treatment, with better services being provided to groups on grounds not related to vulnerability, or differential in access to services or resources of the health systems, like the special drug provision for civil servants in Kenya. There are also quality concerns derived from these equity issues, less control over drugs purchased for those who are asked to go and buy drugs outside the facility, but there is also service shifting that can lead to serious quality concerns and patient safety concerns, like, for example, in Morocco, where insured patients records about 86% of cesarean section among those women who are pregnant. So it's very high and therefore lead to quality concerns. And we saw signs of inefficiencies, as we mentioned in Nigeria, allocative inefficiency through unnecessary referrals to higher level, just to be sure that we keep as much money from the capitation as possible. But all these qualitative indications which require further analysis to be confirmed. And the challenge to unravel this causal link between from payment to incentive, from incentive to provider behavior or provider behavior changes, and from changes to performance is actually quite a complex causal link. And we could not observe any systematic link. I mean by that same drivers, so similar change in payment methods going to capitation or things like that, could have actually different consequences on the behavior of providers depending on the context. And this is something that we really observed. There's no consistency in the way the behaviors are changing across the different cases. And we had also challenges linked to available information, challenges to capture qualitative indications on behavioral changes. It's not easy to get that information from providers because it's not obvious that they will share what they exactly do, right? And the second one is challenges to get data to measure beyond the qualitative indications. And there's actually, right now, very limited data sets on provider behavior in low and middle income countries. And the last point on the discussion is what we observed as well are issues related to governance of provider payment systems. And we could not track from the qualitative discussions the differential in autonomy of use of the different funding flows. But it seemed to us quite important as a challenge for some providers who are held tight by very strong constraint in terms of how they can use funding monies coming their way. And we've seen that in places like Morocco, where public facilities are far less flexible in the use of fundings than private sector facilities. There is clearly a lack of coordination across multiple purchasers. And for example, one case that came out is this cost shifting linked to the differential in payment rates. So same service being paid different rates by different purchasers. That creates a high risk of cost sharing. Or cost shifting, sorry, not cost sharing, cost shifting. And finally, gaps in regulation and weak enforcement capacity, like the case as we mentioned of Morocco, where 86% of the insured are undertaking cesarean section when they are pregnant, while the national rate is only 15%. So in the conclusion, multiple funding flows is a complex reality that deserves more and better attention. The comparison of country analysis was an attempt to improve generalizability, that's complicated, of findings, but it only allowed to produce limited evidence. And we get back to the difficulty also of comparing cases which were kind of different in nature. The financial incentives clearly do not operate in a vacuum. Not easy. Not easy to use, and it's not an easy policy instrument to use as a policy leverage. And the last question I wanted to use as a concluding remark is, and so what? So what are the policy implications of this analysis? Well, first, I think what the analysis, although it only produced limited evidence, it forced us to look at the multiple funding flows together, which is not one specific funding flow versus the other, but really how they combine. And we should really keep on doing that to institutionalize this idea of from a scheme to system thinking, which is needed to understand exactly what's happening at provider level. And that the governance track seems promising to take further action, because it's probably a precondition for provider payment systems to become an effective policy instrument.
Can you hear me? Oh, yeah, all right, okay, good. So we now have a few minutes for questions, either to Fahdi or to myself, about either the conceptual framework or about the empirical findings. We have a mic here. Our space isn't great, so we'll ask you to use the mic if you have any questions. We have a second mic as well. Do you want to come over onto this side, thanks. And then you can manage the top or the bottom. Okay, and please say who you are when you ask your question.
Okay, so my name is Laura Bonsubo. I'm with ThinkWell. I just had a question on, we're talking about cost shifting, resource shifting, service shifting. It kind of implies it's a zero-sum game. But what about we know we should work towards systems thinking, but we also know there are limitations to what we can do with private providers, private health insurance companies, and so on. So if providers have the opportunity to actually increase the size of the pie and redirect some of those resources, I mean, there is some evidence of using resources from private wards and allocated that towards public wards. And have you also looked into those kind of effects? So kind of the indirect flow over effects, my question.
It's a great question. Because one thing I would say is that one of the things we hear from our providers is actually that multiple funding flows actually allows us to deal with the unpredictability of government funds. So it's not all bad. My impression is that the evidence about real cross-subsidization is that it rarely happens. The only time I've ever looked at it, and it pains me that we never actually published it, was in Zambia many years ago. We looked at the hospitals that had high-cost wards and low-cost wards. And while it is true that the high-cost wards had a higher price, they got so much more resources that the net subsidy to the high-cost wards was higher than it was to the low-cost wards. And so, in fact, what you had was the subsidy going in the wrong direction. And so there's lots of talk about using cross-subsidies to improve equity and to be able to plow resources back into the public parts of the facilities, but I don't think there's much evidence that it actually happens in practice. It's tricky. The cost accounting issues are very tricky, but I think one has to be fairly skeptical about whether you can actually charge enough in order to be able to cover the additional resource cost. But more generally, I think this issue about assuming it's hard to investigate without good cost data, and I think that's a real weakness in our empirical base. Yes, please.
Okay, Francis from Nigeria. Just a reflection on the report on resource shifting for Nigeria. It looks like there is a mix of reporting there. What we have observed on the NHIS is a situation where NHIS clients wait longer than those who would pay out of pocket, because number one, the capitation rates and even for NHIS is lower, and providers usually would like those who pay out of pocket, because again, for fee-for-service, it takes time before it comes. So providers usually would want to treat those who pay out of pocket than those who are covered on the NHIS.
Thanks, that's a good point. I think that Nigeria is interesting because the NHIS pays both capitation and fee-for-service. Obinna, did you want to comment on that?
Well, I mean, it's
Here, lean over and talk here. There we go.
Yeah, it's what Francis said is, I mean, it happens, it depends on the state. But where Enugu State, where we undertook this study, that was the finding in a hospital. They actually prefer NHIS patients because they value the capitation that they get from NHIS. So they don't want anything that will make them to lose those patients. So there are different angles too. If you go to some private sector, it's different, but we studied the public sector, and that was a finding.
Okay, thank you. Oh, her. And over here, this lady here. Here first, and then Sunita, if that's okay.
Hello, Dalia from Kazakhstan. I have another question. Like, I agree with you that we should look at these mixed funds, like in general, but not provide the payment policy separately. But I'm wondering if you have considered in your model spillover effect. So if we would reform one part of the system, how that would affect the other one. For example, what I observed in my study, so Kazakhstan has implemented DRGs in 2012. So I'm looking at shift from fee-for-service to DRGs. And I also tried to measure the spillover effect on primary care, and I found that we found that the primary care itself wasn't prepared for that reform, although the policymakers wanted to flip the triangle, so they wanted to prioritize primary care, and like there was incentive for hospitals to increase their cases. But in general, the primary care wasn't prepared because there were some problems there. So I'm wondering if you have looked at that aspect in your study. Thank you.
Fahdi, do you want to respond to that? There you
go. No, we did not look at, well, not directly, the spillover effect, because the challenge to explore such data is that you have to be able to combine the data from the different institutions paying different using different payment methods all together in one scheme and see, okay, now I can have a cross-cutting analysis of the whole effect. And that is extremely difficult to do. That's one of the challenges that I mentioned towards the end. The fact that it's interesting to look at these multiple funding flows together, but it's also extremely challenging to do so at the moment because of that fragmentation. And it's not only a fragmentation like institutions, it's also because if you look at the effect of a change of one payment method of one scheme alone, then you will not, the effect will be blurred by what's happening with the other schemes. So it's, we did not do that.
Sunita?
Nita Sharma from Health Policy Plus Project, Palladium. My question is, like we discussed, there are multiple sources of funding, multiple financing mechanisms, and also different types of payment mechanisms and all things. So because of that, like people are making decisions, providers, policymakers making decisions and trying to whatever the goal or they're trying to achieve. But in this case, can we equip policymakers, implementers with to be able to analyze unintended consequences and really understand interdependence and interconnected nature of the system, how this one decision is going to affect the entire system. So how we can really help them with that.
That's a really great question. I think first of all, raising awareness of it is necessary. So to be able to, as far as we were concerned, I don't think anybody had ever mapped from the provider perspective all of the different funding flows. We didn't actually show any of the maps, but there's a fantastic picture, the one from Kenya, I love, because not only do you have multiple payers, but even for one payer, you have multiple funding streams, even for a particular service. So that there's one payer will pay for maternity services using at least 2 different rates. And so I think mapping it is a first step, but I think there is a process of talking through the implications of that incoherence. But how do we do that? I think it's got to be through generating evidence and bringing it to the table and then engaging in a constructive dialogue about what can be done to reduce some of that fragmentation. I hope some of that discussion can take place in the small group that we're just about to move to. 2 more questions on this side, if we could.
Tim from Peking University. My question is probably related to what just was discussed. Given the study focus on, I think, on descriptional, observational studies, these are mainly observational, but there have been quite a lot of integrated care models around the world, mainly in high-income countries, like joint commissioning in the UK and a lot of different practices in the world. Have there been any evidence from this literature, or has there been some studies on interventions to integrate different funding streams?
Fahdi, would you know any reflections on that?
I think the point of, let me clarify what the exercise was all about. We were at a descriptive stage because it's not been done yet. And I think before you compare to model of cares, a lot of things prior to integration have been governance reforms in developed countries. Because before you integrate this, you need to be sure that you have clarified the mandates of everyone, and that you have triggered that process where you've aligned and create coordination mechanisms across. And this is where it's very difficult. So at the moment, we are just at the tipping part of the iceberg, trying to see what is the reaction of providers to that kind of messy environment. And from there, can we derive some key policy leverage? And as we said, it's difficult to identify, but we deem, or we tend to believe that it's more and more into the governance side of things that you can improve this coordination. In many high income, even in your country, you have a single payer. So that sorts already a lot of issues that are not sorted yet in the countries which we studied, because it's not only fragmented, as Kara said, it's a constellation, because it's a number of purchasers times a number of payments, sometimes times units within that provider, that purchaser, times the number of payment of methods used, and nobody talking to one another clearly. So we're not yet there to explore that.
Joe, are you aware of any evidence from high-income countries about the extent of these? There's a cost-shifting literature in the US.
Right. I was thinking of if the question was also countries that have merged some of their funding flows, and I was trying to think and then realize, of course, that's quite common. In fact, if you think about how some countries where there was, for example, a direct flow from, say, through the budget, Ministry of Health to facilities, and then there is also a health insurance fund, that a growing number of countries, high income as well as middle and some low, have redirected the budget flows into the fund. In fact, like in Japan, I think about a quarter of the revenues of the health insurance funds, health insurance system, come from general budget transfers, so that happens. But it was explicitly done, for example, in some of the ex-Soviet countries, so in Kyrgyzstan and in Moldova, where a lot of the inefficiencies that were found in the way that budgets flowed to providers historically that were driving excess capacity or not linked at all to this, when they established new purchasing agencies and started to redirect the general revenue. So avoiding the problem of having one agency just for the employed and another for everybody else, and instead redirected the flows into the new fund and then created a much more coherent flow of funds to the providers.
To the extent that you can merge pools,
Yeah.
you can achieve something.
So in a way, that was right. It was merging. It was on the between the revenue raising and the pooling is where the merger happened, right? And then one stream to the providers.
Okay, thanks. One last question, Jamila, and then we're going to pause.
Thank you. Nirmala from ThinkWell. Thank you for a great presentation. A quick question, and I'm sorry if I missed this. Did you look at both public and private facilities? And if so, did you see any differences? Because I would imagine private have greater autonomy. So do you see more of this kind of behavior on the part of private versus public? And then whether you also looked at, across the 5 countries, any difference in how aware purchasers were about these kinds of issues and whether they were doing anything about it? Thank you.
So let me address the first part of your question, because on that, well, we did look at private providers for in the WHO analysis, because we had this kind of helicopter view. But when we had to find the common denominator, I think in Resist you look exclusively at public facilities,
Only
right?
Public, yeah, that's right.
So that's why these kind of things we could not extract it from the 6 studies, where it's one of the area where we should expand probably the conceptual framework, definitely. Because we've seen there is for example, Morocco was clearly an example where there was some kind of line itemized facilities, public facilities, which were not incentivized at all for productivity. And a private sector paid fee for service even by the National Health Insurance Scheme. So you had 2 sets of incentives clearly separate for the 2 sectors, explaining why one was producing outputs like ever, and the other one rather controlling costs, and therefore letting patients gradually moving from public towards the private sector, but not in that analysis.
All right, thank you for great questions. We're now going to overcome the challenge provided by our room to try to have a little bit of movement and a bit of discussion in slightly smaller groups. So we've proposed kind of 3 topics for discussion. So one is governance. In fact, so Fahdi's going to sort out the slide. One group to governance arrangements, one to talk about policy implications, and one to talk about research priorities. By my count, we're about 45 people, so I think we'll probably end up with about 15 people in each group. So it's not going to be easy, but I think you'll just have to do your best. So I'd like, and we're going to separate you so you can talk. You can have multiple discussion flows. So I'm going to ask that the governance, people who want to talk about governance, come here. I'm doing it alphabetically right to left. Governance, policy, research questions all over here. So if you can move yourself, and in the front rows, so that you are all kind of sitting together. So 3 groups, 1, 2, 3. We've got 3 facilitators. So Ayako is going to facilitate the governance group here. And Rahab is going to facilitate the policy group here. And Obi, the research group here. You've got 15 minutes, and then we're going to ask you to report back. Research here, yeah. Research with Obinna. All right, everybody. I'm going to ask you to wrap up your discussion in the next 20 seconds. Stay where you are. And, okay, Sunita, you're getting cracking. Okay. Okay, stop. Okay, we're working against a hard deadline here. Thank you all very much for having made good use of our constrained space. I think it was possible to have some very lively discussions, clearly. So I'm going to ask each, you can stay where you are if you like, rather than disrupting us further by moving. So stay where you are. Each group has a microphone. I'm going to ask each group to give the microphone to the rapporteur. You all are still talking, especially over here. Okay, so who's rapporteur in this group? Okay, very good. So Obi, why don't you start with the research group then? I don't think I introduced you. This is Professor Obinna Onwujekwe from the University of Nigeria and a RESIST collaborator. There you are. Hold it close.
Okay, so I think was a very lively discussion. So on the conceptual framework, I think we agreed that we need to explore other provider behaviors, not just the three that we have here. And then in exploring them, we should also explore both the positive, and the negative provider behaviors that arise from multiple funding flows. So that's what we had on the conceptual framework. But on the methods and data sources, we have a lot of ideas. Not very sharpened up, but at least there are some good ideas. We need to look at the effect in both public and private sectors because the incentives are possibly different. We also need to look at different levels of healthcare, from primary to tertiary healthcare. And then, but I think it's one question that came out was, what do we need to know to inform decision-making from this sort of study? Because it will help to guide what we're going to do within each country, since both consequences and health system effects of multiple funding flows will be different in every country. So within this, one question that came out, what are the institutional and governance requirements for each flow? And how do they affect the health system goals? How would information be used to inform policy making? So part of the data that we suggested was actually doing a lot of cost analysis to find out how these funding from different sources actually flow down to the consumers. So many study methods were suggested, cross-sectional, or doing a trend analysis before and after design, in countries where maybe they're going to have some reforms and they know about those reforms. Then the data sources will come from both routine data, admin data, and from surveys, where we can look at utilization data, cost data, and data of insured versus uninsured. So we think this is a study on spillover effect and on intended consequences. We're still discussing about that, about how to sharpen that one up. So this is where we stopped.
Lovely, thank you very much.
Okay.
Okay. Sunita Sharma from Palladium.
So we had very good discussion. We were talking about one thing when policymakers are developing policies. So a couple of the things they can do better job with that. One is really also engaging providers or implementers, because sometimes you design policies and strategies, but when you start implementation, there's so many policy barriers or implementation barriers. Other one also we discussed that when we are looking at data, it's not just always technical information, but political economy analysis, understanding political landscape, they are important. Then we also discussed the fragmentation in financing, payment mechanisms, and sources, and all of those things. And we discussed it's really important to reduce fragmentation, but we then also realized that we cannot completely address it. There will still be some fragmentation. So then we discussed like how do we address it. So we came up with an idea, maybe there are some good examples as well, that one payment system, if we work on that, then we have the one agency is paying all the providers and it's the same rate. So they don't even know if there are different mechanisms or what is happening, but this way we can reduce this fragmentation to a point, especially for providers.
Great, thank you very much. And who do we have as our rapporteur here? Brendan, I can't remember your last name, Brendan. Kwesiga from WHO Uganda.
I think our group is the right one to wrap up because we are still discussing. But there are some key areas we agreed on. I think the first one was the governance structure mechanisms agreed has to depend on the context. We are a group of Nigeria, Tanzania, Uganda, and we are exchanging ideas based, for instance, on our systems, the number of payers there, and we noticed that at least the context, both in terms of how the payments and the flows are designed, but also the provision, will be the first step you would have to consider in thinking through a governance structure. But then having agreed on whatever system you have, thinking through what was presented, there was the reactions at the service delivery level, the response to the signals, and also how the flows are organized. So in terms of how to ensure that the providers respond right, we think you need to strengthen the monitoring role, that's at the service delivery point. But also, you needn't just assume that the providers know what they're supposed to be doing. You may have to strengthen the supervision and mentorship bit so that they know the right thing they're supposed to be doing, and you monitor them to see whether they are doing the right thing. You don't just assume that they know what they're supposed to be doing. And then, in terms of the flows, we are exchanging very many ideas in terms of how to ensure they are coordinated from the top. So if we are finance, health, and a donor sending money down, we should at least be talking to each other, basically aligning our thoughts in terms of the signals once sent down from the top and maybe from the bottom. Of course, that will depend on the structures you have in terms of where the pool can be, because we thought of even you could pool your money even at the start, because it is intended for the same person anyway. So those were the kinds of lines of discussion we're having. It was still going on.
Thank you very much. Well, so lively discussions, and we, in our last couple of minutes then, we're going to turn over to Joe Kutzin, WHO. The number of times that I catch myself thinking, what would Joe say?
Joe would say a lot.
What do you have to say? You have the floor for 5 minutes.
Okay. Well, I did say yesterday that, we're better at quantity than quality, so I hope that's not the case here. A lot to think about. I think one of the things in all of this that I think we're struggling with is the idea of kind of multiple funding flows as a problem, as a challenge, as fragmentation issues, but also when we talk about mixed provider payment systems, that's kind of, that's what we're looking for. That's how countries are evolving. And it's really, and I think as Kara said earlier on, that distinction between an incoherent mix of flows coming from multiple sources without being driven by a unifying policy objective towards progressively moving towards something that is more coherent, which still recognizes that every individual kind of incentive has both potentially positive and negative consequences, which is why in a coherent mixed payment system, you're trying to offset those. So I think in the concept, we have to kind of think about the elements of, whether it's about multiple agencies, so that's one aspect of it, versus a single. And then whether in the multiple flows, it's not just about money and the payment incentives, but also there may be different conditions attached to each, right? Which I think we were hearing about in the presentations. Very often, not always, for example, that let's say if line item budgets are flowing from the Ministry of Finance directly to facilities, that comes with certain rules. It may be that the facility has a treasury account. It may be that that account is higher up. And then it may be that if money's coming from an insurance fund or a PBF agency, there are different rules that attach to that. Some countries are able to do all of this and change things, I think, on the ground to say we can do this all in one bank account and just tag the money. Others have to maintain separate accounts. So when we think about, and this is a little bit of what the discussions in the research group were, to be really clear about our objectives, right? So we want to reduce, from a system perspective, unnecessary administrative costs, like the costs of maintaining 5 bank accounts, or the costs at provider level of having a different form depending on which money source we're dealing with, right? So all of those things, I think, need to come into this conceptualization of it. We're trying to, I think, in terms of, it's not an ultimate objective, but as an intermediate objective, I mean, the presumption is we think that there's a lot of potential for purchasing to be made more strategic as a policy instrument. And the issue of multiple flows complicates that. But keeping in mind that objective and then thinking about what are the different ways that there can be movement to enable that to happen. I was thinking both from a kind of governance and policy perspective and also from experience that I've witnessed, not that I've had. Kara's used this term in other settings about as if pooling, where you can't actually put all the money together, but are there things you can do? One of the main things that I've seen done, this was the case, I would say explicitly done in my experience in Kyrgyzstan and explicitly not done from what I observed in Ghana, was that if you introduce a new funding source or a new arrangement like a health insurance fund, and you have separate flows, it's still possible even from the beginning to unify the data systems and the platforms, so that in Kyrgyzstan, for example, they were 4 years before they merged the flows. But from the beginning, they decided there will be one form for all inpatient discharges. On that form will be an indication of insurance and exemption status and other things. What happened was they built a unified national database, which later then became a foundation for eventually rolling other money in. In Ghana, when I was there a few years ago, I think it's still the case that if you're insured, there's this form, if you're filled out by this department in a hospital. If you're not insured, there's another form. The forms are the same, right? But it's 2 different departments, there's no unified database, and you could move towards having one form with your insurance status as, as one of the fields in that. So thinking about that type of mechanism and instrument, that's really a governance, because it's not really the fault of the insurance fund. In a way, it's the fault of the Ministry of Health for not mandating that, right? So thinking about those types of instruments as ways to make steps towards making things more coherent, because in order to govern any change from where you are now to where you want to be, you need some data. You need to have this information on hand, and to the extent that that data is in one place, you're in a much more powerful position to make change. So I think that part is important. The last thing I'll say, sorry, I'm doing more quantity than quality again, and I think it might have been in Fahdi's talk, and in the analysis of everything, I think you had said that it's really hard to find a very clear causal link between the multiple flows and the results. And from my perspective, that makes a lot of sense because as we saw, there's not like one model, mixed is not a descriptive, not an effective description. It's too big a category. So there's like, maybe hundreds of things ranging from, and that all may, if you think of like our typically very good case of Thailand, right? So you've got the three main schemes, but even there, like with the UC scheme where, the money flows from the budget to the purchasing agency, there are still supply side salaries coming to the providers, and then you've got this, and then you've got the other things like that, and you do see some consequences. So there's that, and there's a whole range of other things. Some countries have direct external flows to providers. So it makes sense that it's hard to find a clear causal link. I think the message is there's not going to be there's not going to be an international comparative regression analysis that says, here's the answer, right? So you're going to have to do in each country really getting into the details of mapping the flows, mapping the incentives, identifying, doing the groundwork to figure it out in each place. I think what can be offered globally is kind of framing the big questions right, so that at least you kind of have the same categories around the objectives and things, but not to expect that you're going to get a global answer to this. I think maybe I'll leave it at that. Thanks.
Okay. Joe, thank you. So thank you all very much. Thank you, people who facilitated discussions and did rapporteurs, and Fahdi for his presentation, and to all of you for making good use of our space. So it's proved to be a really exciting discussion against all odds. So well done, everyone.